I saw that you worked at Benioff Children's Hospital in Oakland as a neurologist for 10 years.
Yeah.
Yeah.
Or even.
Okay.
Yeah.
Okay.
About 12 years.
About 12 years. And that's just at Benioff Children's Hospital.
Yeah, that was my first job.
Really?
Fellowship. Well, medicine, you get your first job at 32. So.
How many years does it take to get your first job when you go into medicine?
So I did 4 years of 4 years of college, then 4 years of medical school. And then I did 2 years of pediatrics, a year of adult neurology, 2 years of pediatric neurology, and then 1 year of epilepsy training. And then I got my first job.
And that was as a neurologist?
As a pediatric neurologist with a specialty in epilepsy.
Wow. Okay. That is a lot of school.
That's a lot.
A lot of training, which is, I guess, an excellent thing if you're going to be a specialist. Like I would hope there's a very rigorous training and education process.
I think there's more debate now about how much can be done on the job and how much needs to be done so formally. It's interesting to kind of watch the tides change in medicine. There's a real there's a real shortage of specialists.
Yeah.
And so the question is, do you need so many years of training to get there? The challenge is that when you're part of training, you're part of this big machine that makes the hospital run. And so there's a lot of benefits to the hospital to have people train longer because they're getting a lot of really good, smart people working for not so much money.
I see.
So, what's good for the system, what's good for the physician, don't always line up.
Right. There are some economic incentives.
There are definitely some economic factors that factor into it all. But it's interesting to see the debate happening now, especially around primary care, because, there's not enough primary care doctors either, right?
That honestly is like a terrifying thought to me, just the idea that we're moving into a future, at least at this moment, where there may not be enough healthcare providers to service the needs of a growing population. Why do you think that that's happening right now? Is it a burnout? There's a retention problem, or is it not enough people going into the field from what you can see?
I think it's a lot of different factors. I think there's certainly burnout. I know, speaking with physicians, they feel like they're a cog in the wheel of a system where their expertise, their kind of what they bring to the system isn't very valued. I think there's a lot of pressure from both patients and administrators to produce, whether that's from patients to kind of get what they need in their care, but from hospital systems and insurers to see X number of patients, right? And so I think there's only so many different pressures physicians want to get. And then there's financial pressures, right? If you're in private practice, it's hard to make ends meet. If every year Medicaid is giving you less and less money, or Medicare is giving you less money, or you're spending more staff time fighting with insurance companies to get patients the care you think they need. So I think a lot of physicians kind of throw up their hands and say, is there a better way to spend my time? Can I impact lives differently in a positive way, but not necessarily do direct care? So what I saw kind of in my generation of mid-career people was a lot of burnout, a lot of people kind of going, hey, you know what? I'd rather go work for a pharma company. I'd rather go do something else. And then, obviously there's a bunch of people who really are super dedicated to medicine and, will keep trudging through no matter what. So I think it's tough. I think there's also sometimes I think there's less interest in medicine, but then I don't know if that's true. I know people are going into other fields. You see these numbers bantered around, but I don't know how accurate it is.
Yeah, and it seems like, I guess, the generations that are coming up nowadays, I guess it would be Gen Z right now. What are they, Gen X, I think?
Actually, I don't remember. I always have to ask my daughter. I'm like, what generation are you again?
Exactly. But I guess, those who are under 25, right, are coming into a world where it just seems like it's an all-time high in terms of potential pathways to be economically viable in our system. And in some ways, a lot of the new options, like, for example, like influencers and things of that sort, which is like the new actor and actresses, entertainer, desire. I mean, it's really seductive, I think, for the younger generations because it meets all of the requirements, right? For what some would say would be like an ideal life in terms of work and life balance, right? Where, hey, I can find a way to align kind of my core purpose or the place where I'm most happy, while at the same time generating economic income, and not have to go through the 9 to 5 and that whole corporate experience, or just being a part of the system, period, right? Let alone being a cog in the system, it's just been devalued, it seems like, at least from what I'm hearing.
Well, I think that, this new generation is doing a service to many of us by asking the question, what do I want? I think many of us just kind of decided to go on the regular path. This is the path, right? I'm going to be a doctor. This is the path. And so then the question is, is that really, is that really the right path? Is that really what my life goals are? And I think it's really important to ask what someone's life goals are. I talk to my kids about that when they're thinking, my son's a freshman in college and my daughter's in high school. It's like, well, you got to think about the kind of life you want to live, right? Beyond getting meaning out of your work. Like, do you want to have a lot of money to travel? Do you not care, right? What is important to you? Because that all has to factor into how you make those decisions. So yeah, if that works for them, great. I mean, sometimes I wonder, are they getting a lot of meaning from it? But, I think that's for that generation to answer.
It seems like, you kind of went the professional path, obviously went the professional path, became a pediatric neurologist, but now mid-career, seems like you're exploring the founder side of things. Are you saying that in this season of life, you're kind of finding a new purpose or new meaning moving into the founder role, as opposed to staying in the system and continuing to serve, as a pediatric neurologist?
Absolutely. I think one of the questions I ask myself is mid-career, you're good at what you do, right? It doesn't take as much work to get through the day as it does when you're earlier in your career. And, the question is, okay, where's my next growth, right? Am I going to stay doing this? Is this enough? Am I going to head towards administration? Am I going to do more research? Those were the kinds of questions I asked myself. And I think, the problems in medicine are so big that I looked around and said, what? I think I need to think about how to address some of these bigger issues. There's only so much you can do as a clinician with the data you're presented. And it's easy as a clinician to blame the patient for not giving you the data that you need to make the best decisions. I felt like it was my responsibility to help provide better data. The patients were doing the best that they could. The families were doing the best that they could, and just needed to, in order to improve healthcare and really change outcomes. I felt like at a certain point, it wasn't going to be a one by one by one, like my clinical practice. I had to think bigger.
Absolutely. And I mean, we spent so much time within the system throughout all of your training, and then now, actually in your role as a pediatric neurologist. And when you looked around and you saw some of these problems that were in the system, what were some of the things that stood out to you, and how did you ultimately decide which opportunity or problem to pursue?
Yeah, it's a great question. So, I think one of the biggest challenges in medicine is really identifying who needs to be seen by who. How do you triage patients to the right people who are the right level to answer the questions that need to be answered? And in the US, there's a total of 60,000 psychiatrists and and only 2,000 child neurologists. And so, child neurologists are a really limited resource, and they have long wait lists. And so when you look around and say, okay, well, a child neurologist can really help with this set of problems, but they're getting a much bigger set of problems that they don't add a lot of value to, for example. Kaiser did a study maybe 10 plus years ago, which showed that for every 5 patients referred to neurology for an EEG, only 1 was getting a diagnosis that the neurologist needed to care for. So, the question is how can you help direct the 5 or to the right person? And that 1 that needs to be seen by the neurologist, get them to the right person so that you cut down on the wait time to get the patient seizure free or to improve their quality of life, and get the right person helping at the right time. And so that's really what I saw was the biggest problem. And then, the other challenge is in California, for example, San Francisco is about midway through the state. there's this whole region north of San Francisco that has virtually no child neurologists. So if a patient needs to come down to the Bay Area to get a basic evaluation, that's a huge commitment for that family, right? Travel, kids taking siblings out of school, lost wages. And so you better be sure that that's going to add value, right? And so those are the kinds of challenges. I mean, 1 in 5 patients travels over 100 miles to get to a neurologist. And in parts of the US, wait times are 9+ months to get to a child neurologist. So even the best trained child neurologists in the world can't help you if you're not there, right?
Exactly.
And, you know, how can you find the patients that would benefit the most from that kind of specialty care? And who benefits the most from staying with their pediatrician, right? Who's much better at ADHD care, for example.
That's really interesting, first of all. I mean, 2,000 child neurologists, and that's just in California or the United States?
That's the US.
That's the United States. That's incredible. Just to give me an idea of, I guess, the scale that we're talking about. Obviously, the wait times are indicative of the imbalance between supply and demand. But when we're looking at, I guess, average number of referrals to child neurologists in any given year, these 2,000 child neurologists are receiving an estimate of how many referrals, generally speaking, in a calendar year?
Yeah, that's a great question. So one child neurologist, you know, if they're full-time in clinic, a lot of child neurologists cover clinic and hospital. So they do both. So the urgent and then the outpatient. I think that probably the best way to think about it would be that a neurologist practice is probably between 1,000 to 2,000 patients in total. So that's the max that they can care for. And when we think about how many kids there are in the United States, right?
Millions,
right? So that's not a very large number, right? So 2,000, maybe say 1,000 times 2,000 in the United States. What is that? Let's see, 200,000 kids. So that's the max, right? Max capacity for child neurology in the US. And you can imagine that to get a 9-month wait list or a year-long wait list, you're probably getting, 5 times that referral.
Right. That is very interesting information, new information to me. And I'm thankful that you've chosen this problem because I'm curious to learn more about your solution to this particular set of problems that exist in this area of child neurology and the significant imbalance. Obviously, there's probably sub-problems within that area. So I'm curious to know what's the specific problem you've chosen and give us a little bit of background about the problem and the current state of things prior to you entering the picture.
Yeah, so I think the big challenge is that neurology scares a lot of people. So in general, even the American Academy of Pediatrics doesn't require pediatricians to have formal training in neurology. And so it attracts a special kind of physician, one who is more comfortable with the unknown and the subjective. That is sometimes a big part of taking care of patients with neurological disorders. And so I think the fundamental problem is that it's very hard and historically doesn't make a whole lot of sense that we've separated out psychiatric disorders from neurological disorders, right? It's the same brain that causes both. And there's tons of overlap in symptoms, and it can be really hard for primary care providers. And these are excellent providers, right? Great clinical skills who just can't, by history, necessarily identify who has epilepsy versus who has maybe ADHD or a different behavioral disorder. And so what that does is it generates a lot of referrals to neurologists who have more expensive tools to answer those questions, like EEGs and imaging, and pediatricians don't have necessarily direct access to that. So it's really the lack of available diagnostic tools at the primary care physician's office that produces this bottleneck of care, right? Where maybe too many patients are sent, maybe not necessarily the right patients are sent. And then, that's what happens on the neurology side. So when I was practicing, I obviously was caring for a lot of patients who had epilepsy, or, a frequent referral is for spells. And so when families kind of describe what they see with their loved ones, they typically describe that the loved ones, looks like they're zoning out, or that their eyes are glazed over, or that they're looking through you. They use very similar words to describe these kind of phenomenon. And, you hear it enough, you guys say, okay, well, I better listen. They're all saying the same thing. And being in San Francisco and the tech capital of the world, right? I got introduced to eye tracking technology. And it's like, oh, wait, if they're all describing the same thing, maybe we can measure it. Maybe we can move from kind of this subjective description to an objective measurement of what people are describing. And so while I was at UCSF, Benioff in Oakland, we were able to do a clinical study comparing video EEG, which is the gold standard for seizure diagnosis, to eye tracking. And we're able to show that we could identify that glazed over look, that it really was a loss of normal eye movements, and sometimes blinking or very specific changes in the eye. And that was kind of the seed that started the company.
Yeah.
And then the other thing is that families report that, when their loved ones is, for example, on a medicine or maybe doing better or worse, it's the same thing, that they can tell because of the way that when they look in their eyes, they're tired, right? Or they're not engaging as much, or they're not looking at their loved ones as much. And so it's the same idea. Well, can we set out to measure those cognitive changes, whether it's for medicine or disease or maybe improvement, and show that we can see those changes. And that's kind of the second component, is really being able to understand not just are there events, but what's kind of the background baseline of how someone's doing, so that we can understand the natural history of the disorder.
Thank you for sharing that. There's a couple of things that stood out to me there. First of all, the separation between, I guess, psychiatric disorders and neurological disorders. What's the thinking behind that? And why are they separated? As you mentioned, it comes from the same brain, but it sounds like one is referring to disorders of the mind, or, at least the conscious mind. And the other is referring to, I guess, biological, electrical disorders. Is that a good way of thinking about it?
I don't know. I mean, it's something that's historical, right? Things that we used to be able to measure versus things we couldn't measure, things you could find in a physical exam versus things that came out on a mental status exam. And I think that's all blurring. So I'm hoping that we catch up to that blurring, and that we think more broadly in terms of neurological health and mental health. So for example, children who have ADHD have a 5 times increased risk of epilepsy. We know that if you have epilepsy, particularly childhood absence epilepsy, the most common pediatric epilepsy, up to 60% of kids also have ADHD. So there's clearly an underlying disorder affecting the front part of the brain in these mental health disorders and epilepsies, right? That's causing difficulties with attention. Yet we artificially separate them. So I think it's more of a historical thing having to do with the history of psychiatry and neurology than it is an actual biological differentiation.
Okay. Yeah, that makes sense. And like most things, right? It's just the way we've always done it. And we continue to do it, and we're not going to revisit and iterate, and evolve the thinking.
Exactly.
That's absolutely, motivated or required to do so. So at least that's what I'm hearing and how I'm interpreting it, but I could be misunderstanding.
Yeah, no, I think that's true. And, for example, one of the challenges is, neurologists are becoming more aware of all the mental health comorbidities present with neurological disorders. Like 50% of people who have epilepsy have depression or anxiety. And you have to look for it, right? You have to identify it. And so it's important to understand how much these things overlap.
It's interesting when we're talking about epilepsy. When we first connected and, we had a conversation and you took me through the deck and you showed me this video, and I forget the young man's name.
It was a video that, there's tons of videos on YouTube and all these other.
I think his name was like Jim or Jacob or something like that. But, you're showing me like this is going to be a child who's going to have a seizure, right? And thinking epilepsy, seizures, in my mind, at least, I think the mainstream association with those words are, I think, very dramatic responses.
Falling to the ground.
Yeah, convulsions, muscle tension, things of that sort. And as I'm like watching this video of this child, he's like talking talking to the person behind the camera, maybe his mother, his sister's running around the background. And then all of a sudden, he just looks off into space and stops talking in the middle of him speaking. And in my mind, I'm watching this and I'm like, oh, maybe he's trying to gather his thoughts. Or maybe he just lost his train of thought and he forgot what he was going to say. And then, after maybe 10 seconds or so, he picks back up where he left off.
Right.
And you tell me that's a seizure. And that was fascinating to me. It blew my mind. I couldn't believe it as I was watching it. And I went and told my wife, I was like, after we got off the call, I was like, I watched this video of this kid who had a seizure, but nothing happened. It was just him staring off into space. And I wasn't even aware that this was a type of seizure, again, because I had my, mainstream understanding of, epilepsy, seizure, things of that sort. And so I forget the name of it, and I would love for you to touch on it a little bit. But tell us a little bit more about this particular type of seizure and how it manifests and how it's a little different than, I or others may understand seizures and epilepsy.
Yeah, so there's what you've expressed is basically kind of a common perception that epilepsy is a disorder where people fall to the ground and shake. But actually the bulk of seizures are considered non-convulsive seizures, meaning people don't shake. They might just stare, they might, make some subtle motor movements, chew, just be unresponsive, uncommunicative. They may just have a feeling that other people don't see. So the type of epilepsy that we're focused on is a type of epilepsy called childhood absence epilepsy. And it was described, I think, in the 1800s.
Wow.
Very classic medicine. Someone saw it in their child, a physician who then was able to describe it. Historically, it's been called petit mal epilepsy. And the kids basically present around usually 4 to 5, peaks around 6 to 8. So school age kids, they look like they suddenly stop and stare and maybe blink, lasts about 10 to 20 seconds, and then they resume normal activity. So if they're walking, they could continue to walk while it happens. And it can happen very frequently. So like 30 plus times a day.
30 times a day?
Like minimum,
At
for some of the kids. Yeah.
Wow.
And it's frequently picked up by the teachers. So the teacher who may have seen kids who have this type of epilepsy will notice that the kid is zoning out. And the challenge is that frequently these kids look like they have ADHD because they, tune out for a while. And so they can get missed or diagnosed as having inattentive type ADHD. And it is the most common pediatric epilepsy. It makes up about 20% of all pediatric epilepsies, about 300,000 kids in the US that are currently diagnosed. So, are we missing them? Probably. I think if you talk to any child neurologist, they all this type of epilepsy kids can grow out of, but they can also continue to have this type of seizure into adulthood, or they can develop another seizure type where they do convulse.
Yeah. And is it still maintained at that same rate of minimum 20 or 30 times a day? Even
so that's pre-treatment.
Okay.
So with treatment, people tend to do much better. Okay. With a lot of them becoming seizure-free. But you have to be treated. You have to be identified so you can be treated. So many times neurologists will maybe see a teenager who has something like juvenile myoclonic epilepsy, which is a type of epilepsy where they do have convulsive seizures. And when they take the history, it turns out, oh, maybe this kid actually had absence epilepsy beforehand. The parents report that they were zoning out and, in retrospect, maybe they were missed. So, I think every neurologist has that story of the patients that were missed. But, it's a very rewarding type of epilepsy to treat because if you can identify the kids, they tend to do really well with the treatment that's been around since the 1950s. It's an old drug. And there hasn't been a lot of research in the space because the seizures are so hard to count. As you saw, if you're a parent looking at it, it's very hard to know if your kid seized, right? Like how many times how's the medicine working? How many times did your child seize since you last saw them? I don't know. The parents look at you like you've got 3 heads. Like they go to school, they play soccer. Like how would I know how many seizures this child had unless I was eyes on them, interacting with them every second of the day, which no parent can do.
It's a lot to take in for me, when I think about it, because again, it just violates all of my like conceptions around epilepsy, ADHD. I also have a family member who was diagnosed with ADD, ADHD when we were very, very young. And that was some of his symptom manifestation in terms of lack of focus, zoning out, things of that sort. And now I'm like revisiting that in my mind. And obviously I don't think, he, had CAE. I'll use that right, as an acronym. But, I've never seen him seize, at least in this way. Certainly not convulsively, but the idea that there are potentially tens, if not hundreds of thousands of kids over the course of, a few years, let's say, let alone a decade, that will be misdiagnosed with a psychiatric disorder, when in fact it's a neurological disorder that's very easily treated, is something that seems to be very, very significant in terms of a problem.
Right. And it's not the pediatrician's fault. It's not that the primary care doctors aren't doing a good job. It's that they're hard to figure out, right? Like zoning out, like unless you actually see the zoning out, how would you know?
That's the standard of diagnosing, a neurological disorder such as epilepsy today. If you were to, for example, be referred to a neurologist, how would a neurologist approach it in terms of the current tools and solutions they have today?
Yeah. So currently, diagnosis is made by physical history. So the doctor's taking, understanding what's going on in the child's life, will examine them, and then we'll also do hyperventilation, which is a method of provoking the seizure type. And then if you can provoke it, then you can see it and diagnose it. And then typically after that, there's a confirmatory EEG to make sure that you have the diagnosis right, that there's nothing else that it could be. And that's how the diagnosis is made. And then usually the child started on that medicine that's been around forever, ethosuximide. And typically 50%, 60% of the kids will respond to that first medicine.
Okay. So the issue is, again, as you eloquently put earlier, is that number one, there are children who in fact do have psychiatric disorders that are being referred to neurologists because they
look just like it.
They
right.
look,
just the pediatrician doing all the right things.
Yeah, and the pediatrician believes that this might be a neurological issue when in fact it's psychiatric, and then that's taking up resources on the neurologist in, getting kind of like false referrals, for lack of better words, when in fact they should be referred to maybe mental health clinic or something like that. And then you also have the children who then get referred to, psychiatric or mental health clinic, who in fact should be referred to neurologists because in fact they are presenting symptoms of CAE as the underlying issue, as opposed to, a psychiatric disorder. And then that's where you're now coming in,
right,
to help clarify and bring clarity to that step prior to the referral, where we can appropriately designate and refer, the children to the appropriate.
Right. So we've developed a digital health tool that allows the primary care physician to, with certainty, decide whether or not to send them to the neurologist or whether or not they need to go down a different treatment pathway. The ADHD pathway, or looking for other etiologies of their inattention. And this is the first tool in our platform. So this tool is really designed for screening, but follow-on tools are really to help the neurologist understand if the patient's responding to treatment. And then future tools are really focused on being able to provide more objective assessment of the child in the primary care office, focused on attention and mood and memory, and being able to get a clearer picture of how somebody is doing at any given point in time.
Okay, so starting off initially with the initial screening and referral, but then going along that patient journey with them ultimately.
Exactly.
Through your platform.
Right. So to provide support for diagnostic choices, figuring out what else do they need, is the treatments working? And because currently it's mostly based on subjective questionnaires, like how are things going in school? How are things going at home? What are people noticing? And that, that very much depends on the reporters. And it can be really hard for physicians to separate out like, oh, well, there was a different teacher last year that maybe the child was engaging with better. And this year they're not engaging as well in this classroom setting. Is it the medicine?
Right.
Or is it the child? Is it the environment? Right. Exactly. So how do you differentiate all these things?
Okay. And so what's your strategy and approach to this initial screening and diagnosis in your current product at the moment?
Yeah. So our first approach is to do a lot of education around, what is childhood absence epilepsy, who should be screened, specifically the kids who have inattentive ADHD, in addition to anyone who comes in complaining of staring spells or zoning out spells, and then really get clinicians used to that. And I think the big win is that the neurologists are bought into this. So they really want the primary care physicians doing it, because then if the test is positive, they can go, oh, this kid's actively seizing. I don't want them to wait 9 months. I'll see them in the next 2 weeks or week, so that, they don't injure themselves. They don't have more school loss, educational loss. And so our strategy is really to show how it's a win-win for everybody. It's a win for the patient because they get on the right diagnostic sooner, right treatment sooner. It's a win for the physician's office because they're not, they can decide at the time what needs to be done. They can bill for it. And so their time is reimbursed as it should be. And then the neurologist at the same time is also able to put their focus on the critical patients that need them. And so it really helps the patient, it helps the physicians, and it helps the system.
Your product is launched in the market currently, correct?
Yes. Yeah.
So tell me a little bit about how things are going with your current cohort of pediatricians and primary care providers that are utilizing your product.
Yeah. So we've had a very positive response. I think people are really excited to be able to use it and get the information. What's really interesting about it is that, we don't expect a high hit rate, right? They may be screening, for example, 20 kids to find one positive, but even the negatives have a big benefit, right? Because they aren't sending those kids to neurology. They're going, oh, okay, let's go down this other treatment pathway. And so we've gotten a lot of positive feedback about that. We recently had one positive that was sent to the neurologist, and we were able to show, hey, look, they did get in very quickly to the neurologist's office, went down the right treatment pathway. And that was, very powerful in a state where there's a 9+ month wait to get to the neurologist. Physicians are getting paid. So that's a big challenge in the medical space, is really showing that the reimbursement in place and that they're getting paid for their time. And so that's been a big plus for us to validate the use case, right? But in addition, to validate the financial models that we have developed as a company. So yeah, it's really about now, it's about scaling, getting the word out, getting, lateral referrals from physician to physician, for us to do additional marketing, and, get everybody using it.
Yeah, absolutely. Absolutely. And I'm glad that it's in the market, number one, and it's already making an impact. Getting the pediatricians and the primary care physicians on board, so that way the ultimate benefit goes to the patient. Seems to, be challenging at times for some founders. And so I'm curious to know, out of the pediatricians or primary care physicians that you have encountered, with your proposition for, your diagnostic tool, what are some of the common feedback or responses you get in terms of the pitch, the value of your product, or any barriers that they may be facing?
Yeah, so from the positive, the American Academy of Pediatrics put out guidelines in 2019, really stating that you need to look for childhood absence epilepsy. When you're doing an evaluation for ADHD, if you make the diagnosis, to look for common causes that are also present with ADHD, and if treatment is failing. So it's great to be able to point to, hey, look, you're a pediatrician. This is your academy that says you should be doing this. So that's a big positive. I think there is a perception that it's not very common, and that they don't really see it. And, does it make sense to look for it? I would say that's kind of the biggest barrier, is to do education around the frequency of it, of childhood absence epilepsy, and the benefit of ruling it out. And by ruling it out, you're saying, okay, this isn't that frequent. And physicians do this all the time, right? You look for things that aren't common, but very treatable, because you don't want to miss that, right? You don't want to miss the child who has a vitamin deficiency when you could just give them a vitamin.
Exactly.
You don't want to miss the child who has childhood absence epilepsy when it's easily treated, and instead go down the ADHD pathway. And so, kind of teaching the benefit of ruling out in addition to ruling in is one of the things that we found the most valuable in that sense.
Absolutely. And it fascinates me because I'm wondering, given how easy it is to misdiagnose, CAE, I'm wondering if the perception around how uncommon it is actually based on flawed data, right? Where if you're looking at the total number of diagnoses in a population, that number is actually baking in a bunch of misdiagnoses that are then now being reflected, and people are building, their perceptions and I guess utilizing the data in a way that is for their benefit, but actually is bad data to begin with.
Yeah, I think that's an accurate kind of thing to point out, which is all our prevalence data is based on the kids that make it through the system, not the kids that are missed. It's a challenge, right? We are looking to do that study, right? To say, take all the kids, for example, who might be referred to neurology and say, what's the actual frequency of this disorder? It just takes a lot of money for a little startup, and the NIH has been wonderful in that regard, supporting our clinical studies. So we will be applying for a grant specifically looking at that in the near future.
Can you speak a little bit about the impact from the experience that child will have between the time that the seizures start and the time that it actually gets to a point where now people are sure they now have an epileptic disorder, and how early diagnosis can affect that child's experience moving forward?
That's a great question. Nobody's done the study of like, hey, what happens if we treat earlier versus later? Because obviously everybody wants to treat the moment that there is a diagnosis. We do know from other epilepsies that the sooner you treat, the sooner you get the child seizure free, the better they do overall. That while a child is having active seizures, it's much harder to learn. It's much harder to pay attention. And that if you can quiet the seizures down, then you can focus better, right? I mean, if you're losing 10 seconds, 20 seconds, multiple times an hour, it's hard to follow what's happening in school. And the kids, they don't know that they're losing time. So it's not uncommon for them to get teased by other kids. And so there's a social stigma associated with it as well. There's pretty significant challenges. And then there's also the risk of injury. People who have untreated epilepsy are at risk for injuries. I'll never forget one of the patients I cared for who came in with a new diagnosis of absence epilepsy and had a broken arm. And I was like, what'd you do? And he was explaining that he loves climbing trees, and he climbed a tree and he doesn't know why, but he fell out of the tree. Well, he probably had a seizure, right? Lost consciousness, fell out of the tree. You don't have to have much of a movement, right, to fall out of a tree, but enough of losing a grip or whatever,
right,
and not being aware. And that's probably why he broke his arm, right? So untreated epilepsy when you're walking around in the world can be dangerous for kids, in addition to the social stigma and the educational loss. And so the sooner you can get things under control, the sooner they can lead a normal life, the sooner you can intervene if there's other things present like attentional disorders or anxiety or depression, but that all needs to be identified.
Is it likely that untreated CAE, where the child is now going through these social pressures and the stigma, is it more likely that they develop additional comorbidities that are more psychiatric disorders, such as anxiety, depression, things of that sort, as a result of this misdiagnosis?
So you can get it either way is the challenge. So we know that depression, anxiety, attentional disorders live with epilepsies and frequently predate the epilepsy diagnosis. So, but I know from my own patients that all those symptoms can be exacerbated by social stigma and educational loss and struggling, right? We all know that from our personal experience that, yes, you can have those symptoms, but they can certainly get worse, or they can be, become much more problematic when stressed.
Mm-hmm. Okay. Yeah, that seems to make sense to me. And again, I'm like processing some of this in real time, and forgive me if the questions are a little choppy. But
No, it's a space people. I always say that epilepsy is kind of where women's health was about 20 years ago. It's something that's like not talked about, right? It's even today, there's still so much education that these foundations are trying to do to make people more aware, make parents aware, so that they can be the ones to bring it to their doctor's attention, right?
Mm-hmm. Absolutely. So you touched a little bit earlier about, I guess, the high level vision for the platform, not starting off in screening, but then growing to include tools and products for the full patient journey. Would love to kind of revisit that and have you kind of talk a little bit more in detail about that particular vision. Some of the, I guess, reasoning and thought behind wanting to move kind of downstream in the patient journey and the ultimate impact you hope to make with a fully built out platform, let's say a few years down the line, where you're now able to not only go from the screening, but all the way through to the continuation and monitoring of treatment.
Yeah. So I think a way to think about it is that, if you're going to diagnose someone with the flu, right, you need to know what their temperature is. So without having objective markers in neurology or psychiatric care, it's very hard to monitor if somebody's flu is getting better, right? Like, are they doing better? Are they doing worse? I mean, I remember having conversation after conversation with family members about, maybe the kid's not doing as well in school. Is it the medicines? Is it the epilepsy? Is it they went from kindergarten to first grade and now we're demanding more of the child? And we just don't have the data to tease all of that stuff apart. Now, we do have great tools like neuropsychology, but if you think neurologists are hard to access, neuropsychologists are even harder to access. And, a comprehensive neuropsych exam costs between $3,000 to $5,000 and can't be repeated more than once a year, right? So how do you know if the last change made somebody better or worse that you did to their medicines? Or is this the disease state? Or is this something new and different? And so being able to have objective markers, whether it's for epilepsy or multiple sclerosis or depression, we need to know if someone is doing better or worse. Like, it's just a fundamental problem in medicine that how are you going to, for example, develop new therapeutics to treat these disorders if you're relying on questionnaires that have huge error rates, right? And what we're doing is we're putting the responsibility back on the patient to tell us how they're doing. So, you tell us how many seizures you've had. You tell us how you're feeling from your depression.
Right.
And, it's not fair at a certain point. They can't, either they're unable to share that information or they don't. In the case of childhood absence epilepsy, kid doesn't even know, right? They never laid down the memory that they had a seizure. So how are they supposed to tell us, my seizures are 50% better now, so the fundamental problem in these disorders that I think a lot of startups are trying to address is how do you get a thermometer of the disease, right? How do you know if someone's getting better or worse? And that's really what my goal is. And not to necessarily make it disease specific, but to, say, okay, well, I can measure your attention. I can measure your attention whether you have multiple sclerosis or you have dementia or you have epilepsy, right? I have metrics of attention. It takes 5 minutes to do this test. All right, well, I can measure your mood. I can understand your feelings of sadness, irritation within 5 minutes, and we can follow that over time as as we're making interventions or as things change because of your age or whatever other factors are going into play. And so ultimately, to move neurologists to kind of like a different treatment algorithm, we have to take that burden away from families and really put it on devices and objective markers like other fields have done, right? It's just harder in the brain. And so that, I think, is really what the opportunity is to change outcomes.
Absolutely. That's powerful. And will definitely transform patient lives. Once it's built out, you develop those markers. like you said, now we can start improving care in a very, very precise manner, just having the available data.
Yeah, I mean, and a good example is childhood absence epilepsy, right? There's been no new FDA-approved drug since the 1990s. 30 years in. It's the most common pediatric epilepsy. Why is there no new drug? Well, there's no new drug because you can't measure how the seizures are doing, right? So without the tools, you can't develop the new therapeutics to intervene.
So you mentioned hyperventilation as a part of the diagnosing process. What's the relationship between hyperventilation and seizures?
That's a great question. So when you're exercising, you hyperventilate, right? You breathe faster because your body needs all that oxygen. But what we're doing is hyperventilating people when they're not exercising, when they're sitting still. And so instead of compensating the excess CO2, you're now losing all that carbon dioxide, and it's changing the pH in your blood. And when you change the pH in your blood, it affects the pH in the brain. And because this is an inherited type of epilepsy, all these channels in your brain are very dependent on what the acid base level is. And so it provokes seizures because you're changing that acid base level in kids who have a tendency towards seizures, meaning that they have epilepsy. So it's basically a chemical process that's provoked from breathing off all of that CO2 in your body.
Excellent. And then by provoking the seizure,
then you can identify it.
And you can identify it and then make the correct referral. So Rachel, it's been great to chat. Before we conclude our conversation, I would love to know what's on your roadmap moving forward. Took a look at the website, saw a list of accomplishments that you've had up to this point, ton of milestones you've achieved up to this point, but would love to know what's the next milestones you need to hit moving forward to get to the next step in the journey for you and your product?
Yeah, so, we have kind of multiple focuses at the same time. Currently we're running clinical studies supported by both the National Institutes of Health and the National Science Foundation. So the NIH study is run at Cincinnati Children's Hospital. And we have enrolled about 40 kids who are at risk for absence epilepsy. Basically looking at our device compared to the gold standard, which is video EEG. And it's exciting that our preliminary results have almost 100% sensitivity and 92% specificity, meaning we're picking up all the seizures, which is really exciting. The National Science Foundation is currently supporting development of our attention-related products and mood-related products. So that is also in the works. And then our big push is really getting our product to market. So developing a really scalable way of selling so that we can really penetrate the market and get the sales numbers that we think will allow us to reach our next inflection point, which is just really all about getting pediatricians to buy in, use our products, understand the value, and give us feedback so that we can continue to grow and meet the demand.
Absolutely. Well, congratulations on all the progress so far, and I'm looking forward to seeing all the amazing work you're going to do moving forward. And I really want to thank you again for taking the time to speak with me today and for giving me the opportunity to participate in your journey directly. I feel incredibly privileged to work with you and to be able to support you along your journey. And I'm looking forward to seeing all of the amazing things that you're going to do in the future.
Well, thanks so much. We've really enjoyed working with you.